Hello, everyone, and welcome to the Meeting the Opioid Challenge in the Emergency Department webinar series. Today, we're going to be focused on treatment, referral workflows, billing, and resources. Next slide. As we begin, we just have a few housekeeping things, and then we'll go right into the webinar. So for today, all participants will be muted. Feel free to ask any questions that you may have in the chat or in the Q&A function. If you are unable to use either of these functions, please feel free to submit any questions that you may have to my email address, which is samantha.lasky@iphionline.org. And stay tuned at the end for a Q&A session with our speakers, as well as some information about how you get your CME credits. And I will go ahead and pass it over to my CEO, Alyssa Bassler.
Hi, I'm Alyssa Bassler, and I realize my screen is very dark. I don't know what happened to the light in this room. I apologize for that. I'm Alyssa Bassler. I'm the CEO at the Illinois Public Health Institute. We are partnering with the Chicago Department of Public Health and our subject matter leaders in this field who are on this call to work with Chicago emergency departments to increase their capacity to respond to the opioid crisis. Specifically, we're working on how do we increase the availability and the dispensing of naloxone to patients who come into the emergency department. How can we initiate buprenorphine and connect patients with opioid use disorder who want treatment to community-based treatment, and or how we can connect those folks with opioid use disorder directly to the new state initiative called MAR-Now. Next slide, please. We've been working on this in different iterations for about 4 years with the city of Chicago. Today, the objectives for the meeting are to discuss referral options, including MAR-Now, that was introduced in 2022 to provide immediate treatment and counseling, describe the underlying changes to workflow, how to become a DOP site for naloxone, how to do the EHR documentation for the medication-assisted recovery treatment in the emergency room, how to do the documentation and what the billing code is all about for this service that we were able to achieve through some advocacy and policy work that we did a few years ago, and where you can go for some immediate assistance with dosing and other questions about initiating treatment in the emergency department. Next slide. We have continuing education, medical education units available for people attending this. We'll give you some more information at the end for that through the University of Illinois College of Medicine at Chicago. And it helps to reach some of the credits that you're required for your DEA accreditation around opioids. Next slide. So this is the fourth of 4 sessions. The first one a little over a month ago was around general, broad, high-level information about meeting the opioid challenge in the emergency department, where the field is going with that, how to meet the emerging standard of care. And then earlier this month, and then we did a fantastic presentation about overcoming stigma and bias, which is a huge barrier to people getting treatment and saving lives. We then did sort of technical detail about how to do the medication-assisted treatment induction in the emergency department from a technical and risk and dosing standpoint. And then today, we're focusing on sort of the nuts and bolts of doing the treatment, getting payment for it, putting referrals in place as required for the payment and workflows and so on. All of these webinars will soon be available online also for continuing medical education units. So if you think this is useful, we'll be able to share this with you to share with others in the future. Our presenters today will introduce themselves in a little more detail. Dr. Jess Richardson, Dr. Steve Holtzford, and Dr. Diana Batari, and also Dr. Nikki Gastala from the Department of Human Services, who's unfortunately, we don't have her picture here, but she will introduce herself. So I'm going to turn it over to our speakers to introduce themselves and get into more of the meat of this presentation.
Dr. Holtzford, do you want to just introduce yourself?
Yes, I will do that. Can you guys see me?
Mm-hmm.
Okay, sorry. So my name is Steve Holtzford. I was an ER doctor at Del Nor Hospital. There I am. I was an ER doctor at Del Nor Hospital in Geneva, part of the Northwestern system, for years. And about 5 years ago, I started to become interested in addiction medicine, and now I'm doing addiction medicine exclusively in a lot of different settings. But I really have a passion for sort of elevating the care of patients struggling with substance use disorder within the ED, which led me to this project.
Wonderful. And I don't see Jess on. Dr. Richardson is another one of our subject matter experts. There may be some delay in her getting on, but she is one of our partners in crime. I'm Dr. Diana Batari. I'm the medical director for Controlled Substance Monitoring Team for Advocate Aurora Health. My background is also addiction medicine, and I'm very happy to be part of the Illinois Public Health Institute team to help combat the opioid epidemic. And we are joined today by Dr. Nikki Gastala, and I will let her introduce herself.
Hi, everyone. Thank you so much for having me today. IPHI has been really working hard in collaboration with CDPH the past few years to really improve access for patients with opioid use disorder, particularly in hospitals and ED settings, and working on some great access in terms of naloxone as well. So I get the opportunity to get to talk today. So with you all about a program that we started on the city side first, and then expanded to statewide called MAR Now. So it stands for Medication Assisted Recovery Now. And actually, we're using the telehealth hotline that already exists, the Illinois Helpline, to provide immediate consultation, medication management for opioid use disorder, as well as referral to local definitive care. Next slide. So the reality is that in terms of the importance of morbidity and mortality, is medications for opioid use disorder really impact that, right? So in medicine, we use the number needed to treat to prevent one death in 1 year. So you need to treat about 415 patients with a statin to prevent a death from cardiovascular disease. You need to screen over 2,900 women to prevent 1 death from breast cancer. You need to start 33 patients on buprenorphine or 31 patients on methadone after an overdose to prevent 1 death in 1 year. So as you can see, that number is pretty substantial and important, and really is evidence-based in terms of standard of care. Next slide. So we'll kind of go through the program overview, and then how you connect patients, what is included, and then also some of the data, because that's also pretty important. So this was started in May 9th, 2022 as a Chicago pilot, and then expanded statewide on September 1st of last year. It was a collaboration between CDPH, IDHS, and SUPER with an organization called Family Guidance, and it operates through our 24/7 Illinois helpline. So you can call that number, have the patient call that number. What it does is it provides low barrier rapid access to buprenorphine via telehealth, methadone in person, or naltrexone via telehealth to all callers, regardless of insurance status, income, ability to pay, or documentation status. Because of the changes in COVID, during COVID, we've been able to prescribe buprenorphine and naltrexone over the phone. Methadone, you still require that in-person visit, but we can at least be able to coordinate that pretty rapidly. Next slide. So the idea is that any individual or a clinician, right, who wants to help a patient get access can call the Illinois Helpline 24/7. They'll direct that patient to an MAR Now care manager, and that care manager, they'll then talk with them through different options, right? Does the patient want to do buprenorphine? Do they want to do a same day appointment for methadone or next day appointment for methadone or naltrexone? Are there any other services that they're interested in or meet criteria for, including withdrawal management or residential treatment? And then through the grant funding, care managers will provide free transportation, assist with insurance enrollment, with pharmacy access, confirming that the medication makes it to the pharmacy and that they can pick it up, and then follow up to make sure that the patient is connected to long-term care. Next slide. So really what the goal is to reduce as many barriers as possible, right? So remove all of the challenges that patients face because of disorganization within the healthcare system, right? And the siloing within healthcare system. So that case manager helps connect the patients to the pharmacy, mental health providers, harm reduction providers, primary care providers. They can work with the local Cook County Jail, homeless shelters, encampment outreach, and then with the ultimate goal of connecting the patient to a community MAR provider for long-term follow-up. So that's really the goal, is to be a bridge clinic for that patient. So where can you initiate it? Well, really everywhere, right? In the ED, you can ask the patient if they're interested in starting medication, restarting, or being connected to services. You just have to give the patient a phone. You can let them borrow the hospital phone, or if they have a cell phone, can call directly. And then from there, the MAR team will take the next steps. It can be following a hospital admission. So ask the patient if they're interested in starting medication, restarting, or being connected, and then have them connect with them prior to being discharged from the hospital. If it's urgent care outpatient settings, still same thing, call that number, and then we'll take it from there in terms of starting the patient. If you're interested in starting the medication yourself, that's fine. You can actually request a doc to doc, and they'll support you in doing that first prescription. If you don't feel comfortable, that's all right. The doc on call will then take over and do that prescription for you. Next slide. So why do this? Well, it positively impacts the opioid epidemic in your communities. It can ease, decrease the burden to your staff, right? And improve connection to services without increasing clinical staff. It also fulfills the Joint Commission requirements for hospitals under the chronic pain management standards to have a mechanism for referral for patients with OUD, right? So it meets that criteria. So let's talk a little bit. So we talked about the program, how to access it, when you can use it. There's pretty much no wrong answer. Just call and get the patient connected. But now the question is of course, well, does it actually work, right? And that's, luckily we have 1.5 years of data for you that we can sort of share. So this is the last updated data that I have, which was May 9th through April 23rd. And this shows that there were 474 patients that requested care. 30% wanted methadone, 61% wanted buprenorphine, 6% wanted medical stabilization or withdrawal management, and 3% wanted residential treatment. Of those patients, 75% who wanted methadone attended their first appointment, so it was an actualized referral. Buprenorphine patients who were connected to medication, 99%, 96% of the patients who wanted withdrawal management showed up at that appointment, and 85% showed up for their residential treatment appointment, if that is in fact what they wanted. So you can see that care management piece of it is actually really critical in getting that patient connected and to that first appointment. Next slide. What we learned was that by providing transportation, working with outreach, the pharmacies, doing intensive follow-up, and utilizing the existing helpline, we were able to really impact patients who are interested in services and provide education and treatment around buprenorphine for patients. And so next time, if you're in the hospital setting and you've got a patient who survived an opioid overdose, or they're there for opioid withdrawal or complications of OUD related to their hospitalization and they're interested in starting on medication, just get them connected and we'll take it from there. If you are interested in becoming a community provider for these patients, we are always looking because the idea is that they follow up locally. And this data wasn't included in these slides, but I've got the data, and it does, the patient enrollment within the community was really high at 4 weeks. It was over 90%. So most patients do get connected to local care after, and that's sort of the goal, right? Is that they get connected to local resources. If you have any feedback based off your experience of calling with a patient and you think that things need to be improved, then please send me an email or Dr. Bruni. And then just to let you know, we are working with an external evaluator, again, to really provide that information. All right. And another sort of important area is that really to sort of understand that, again, medication-assisted recovery is effective treatment, that buprenorphine and methadone are very effective for patients in terms of retention, which is directly correlated with a reduction in morbidity and mortality, as well as reduced illicit drug use. And so they're both really evidence-based practices that we should be incorporating as part of our medical treatment. Next slide. And here's the sort of research that has supported telebuprenorphine that we've luckily been able to gather during the COVID pandemic. All right. Thank you.
Thank you, Dr. Costello, so much for presenting on Marnell. I think people really should understand how unique this is and how amazing this is. This is an opportunity that we have in the state of Illinois to be able to reach out to care so easily and even do a doc-to-doc call if you are stuck. And you need a little help. So I think the work you have done has been outstanding. So thank you for all of your work and for presenting for us. We appreciate it.
Thank you. I'll put my email address in the chat. And if anything else comes up, please feel free to reach out or any questions.
Thank you. All right, so we're going to go on to the next part of our talk. And this is just a little quote that it's always the simple that produces the marvelous. And that's really true about what we're talking about here, because we're talking about two very cost-effective ways to treat opioid use disorder and to save lives, which is Narcan, which is free for us in the state of Illinois because we are awesome, and then buprenorphine to treat the opioid use disorder. So now we get to kind of the nuts and bolts of what to do kind of thing, okay? The step-by-step stuff. The things that you may not think about, like what to stock in the Pyxis or the Omnicell. That's a really, interesting question and something that's really important to kind of talk about because of cost implications. So when we talk about Suboxone, which is the combination product of buprenorphine and naloxone, that product itself is much more expensive. And the idea of the naloxone being in the product is actually abuse deterrent, meaning that the person cannot misuse that medication by melting it, injecting it, those kind of things. Well, when we're in the hospital and we're giving the medicine to the patient, we're watching them take the medicine, that is not something that we really have to worry about. So we can use straight buprenorphine, also known as Subutex, because it's less expensive and we don't really need to stock that Suboxone product. We can stock just the buprenorphine. Again, it's less expensive. What we would suggest is stocking the 8 milligram films. They can be cut in half if you wanted to start with 4. But with initiation, a lot of times, especially anybody who has any kind of heroin disorder or anything like that, that would be a better way to do things. So again, buprenorphine would be the one to stock in the Omnicell and Pyxis. And please feel free to ask questions in the chat, especially about these things. We might be able to help you and kind of lead you down the right way. So that's step 1, what to stock in the Pyxis as it relates to buprenorphine products. Now, the next part is a really important part. Now, people on this call obviously are dedicated to this. That's why you're listening to it. But what you need to do is really select champions, and that is a physician, a resident, an ED pharmacist, and a nurse, because we need both sides of this. This isn't just one person. This is everybody, okay? This is everybody's initiative. We need the nurses to help. We need the docs to help. We need the ED pharmacist helps. And if you work in a resident run facility, that is another great place to start. So you need a champion. And the reason for this champion is to help with education. Yes, we're educating here, but then you need to bring it out there. We need to bring it to the people that are actually seeing the patients, to the ED staff. We need to break that stigma, and those champions can do that. They really can use this material that we have here or various other sites to really start breaking down the unconscious bias and breaking down how we think about opioid use disorder and substance use disorder in and of itself. Again, our words always say that it is a mental, like this is it's a physical problem, right? Your brain is reacting to something. We know this, right? It is not a choice. However, the way we respond to opioid use disorder and substance use disorder is more like that was that person's choice, right? And so this is how these things can help be broken down by selecting the champion and also leading by example. If we have ED docs that are real big champions in starting Suboxone on these patients and others see how well patients are doing, then they want to do it too. So it's really important that you look for a champion in this. And hopefully you're one of the champions. Also creating things to make things easier. So people are always going to take the path of least resistance, and they're going to take the easier path. And in ED and the hustle and a bustle of the ED, it's really important to make these steps as simple as possible. Make the right choice, the simple choice. And that can be helpful by creating an electronic medical record order set for buprenorphine. This way, it's just you click on it and it kind of auto-populates all the great things that you need in order to do a bup induction. Now, I would also create an algorithm, and this would be for clinicians to refer to. Now, many of these already exist. This is the great part of this, is you don't have to reinvent the wheel. These already exist. Even if you guys are on Cerner, you're on Epic, these order sets already exist as well. So this is very simple to be able to do and to replicate. Now, here's an example of my hospital, which I work for Advocate Aurora Health. This is an example of the medication-assisted treatment algorithm that we designed for the ED. Again, it looks a little bit busy, but it's actually very simple to follow. And then this algorithm fed into our order set, our buprenorphine induction order set, because we want to make the right choice the easy choice. And again, 1, 2, 3, right? We want to make sure that we have diagnosed a patient with an opioid use disorder, that the person has chose recovery or wishes to use a buprenorphine product, and then start the induction process. Give the 8 milligrams, see how they feel, and then repeat it if necessary. Now, the other really important part is the naloxone kit. So again, in the state of Illinois, we are pretty awesome in the fact that we have free naloxone, okay? Not a lot of states have this. And how do you get this free naloxone if you haven't already done that? Well, you're gonna register to be a DOPP, and that is a drug overdose prevention program site. And if you go to this website, you can see there's a little box that says hospitals and clinics. And you click on this little box. It is extraordinarily simple. And here you go, and then you just kind of put in your organization's name. You put in your project director's name, which would be the person that's ordering the naloxone. You put in the title, the address. Very, very simple. Now, they are asking for some information, and the information is kind of outlined in here. It is not anything with PHI on it, so we don't have to worry about that part of it. But really what they're looking at is zip codes, diagnosis, primary diagnosis, secondary diagnosis, so that we can kind of feed a larger depository of information so that we can figure out, if we saturate a market in naloxone, what happens, right? So they want to track this data, and I think it's a really great thing to be able to provide. Now, then all you have to do is put in today's date, put your date. That's it. It takes less than 5 minutes to register as a DOPP. Very easy to do, and you're able to get your Narcan. So once you do that, you get an email that gives you your login credentials, and this comes directly from Narcan Direct, which is the vendor that is being used by the state. You go to their website, you log in using your username and password, and you order the Narcan. It comes within 2 business days, and then you give out the Narcan. It is really that simple. Again, my company that I work for is across states. So I really value Illinois very much so for having this opportunity for us to give out this free product. Because again, patients that die from an overdose can't achieve recovery. So keep in mind that naloxone actually no longer requires an outpatient label. That was a really rate limiting step for many different hospitals to give out Narcan, was how do we label it? How do we order it? How do we do all these things? So that outpatient labeling requirement is gone. In addition, you can actually give out the naloxone not only to the patient, but you can actually give that out to their friends and families too. So if somebody else is there, you can actually give the product to them. And it's free. I mean, I cannot underscore that enough, that it's free to the hospital, it's free to the patient. It is amazing to be able to do. The record keeping can be done through your electronic health record. This can be done through reports on Epic and the same way through Cerner. And anyone can give it away, okay? So anybody can give it out. So your nurses, your advanced practice clinicians, your physicians, your pharmacists, everybody's able to give this to the patients. Now, here's an example of how we did it at our institution, and that is our naloxone program ordering guide. Again, anybody can order it. We even have on here the behavioral health crisis team can place the order. We consider ordering this or giving this out to any patient with an opioid overdose, a history of an opioid-related event, history of substance abuse disorder, or patients that are requesting naloxone. So you can see that anybody, even with a substance use disorder, we also offer this to. And why do we do that? Well, that is because we know that a lot of drugs are being contaminated with fentanyl, right? So we know cocaine is a big one that gets contaminated with fentanyl, but also benzodiazepines get contaminated with fentanyl. So we want to make sure that we have that naloxone in hand. So it's not that we just offer it to opioid use disorder patients, we offer it to substance use disorder patients as well. Now, once identified, what we did from program materials is we actually use iPads or WOWs, which are the portable, used to be called cows, the portable computers for the patients and or family members to watch videos on how to identify an overdose and how to administer the Narcan. We also developed written education to go in the after visit summary, and that automatically populates. Again, all of this, like the easy way, the right way, right? We want to make sure that this is as simple as possible for everyone. So anything that you can do automatically is always good. So the nurse can prompt the physician or the pharmacist to put in the naloxone order. So if a nurse identifies a patient, they can say, hey, doc, can you put this in? We have an order that we placed or that we put into Epic that is a no charge naloxone order. And this way we can really track who's getting this free product. The order then populates to our pharmacist then verifies it and tubes up the naloxone product. In our case, we actually did make a label because the label requirement was there when we started giving out the naloxone. So we still use the labeling, but that's no longer required. So that step is something that you don't really have to do. You can kind of just put it in your Pyxis at this point. Again, we have it so that in the electronic medical record that you can default it for take-home med. So this is really, really nice to be able to do. Again, no label required. So this is even easier to give out. So this is an example of our patient education that auto-populates. And what it goes over is it really goes over how to identify an overdose. Now, remember, if you're overdosing, you're not giving the Narcan to yourself. So we want patients, one, never to use alone, but two, be able to identify that overdose in somebody they're with. So being able to see it, understand it, know how to recognize it, and then know how to administer the Narcan is really important. So these step-by-step instructions are also included automatically in the after visit summary when we give a patient a take-home naloxone product. So one of the questions that we had even on the last webinar was really about billing and documentation. So there is a new code. It is G2213. This is an add-on code, meaning that, a lot of times it's a bundle for the ED from a coding standpoint and a billing standpoint, but this you can actually do on top of that. Okay, so this is a separate code. Now, what this code is it's paying for induction of buprenorphine in warm handoff. That is what it is. That is what is reimbursing for. So you do need to make a dot phrase. A dot phrase is easy to then add to your note again, I can't stress this enough, make the easy choice the right choice, right? So you make a dot phrase. And in this particular dot phrase, we have patient diagnosed with an opioid use disorder. Through motivational interviewing techniques, patient is agreeable to receive buprenorphine induction and referral to outpatient services. Patient was inducted with X amount of milligrams of buprenorphine and supplied with so many days supply of buprenorphine. Patient given MAR-now number and or follow-up care instructions. Patient also giving naloxone either in hand or prescribed and understands the high risk of death if patient returns to opioids. Patient understands never to use alone and always could carry naloxone. So this is an example of something that you can make that your providers can then put in their notes. We are working with the state on what the definition of initiation of buprenorphine and whether or not they would include home induction. We haven't gotten there yet. Now, the original handout or the original notice to providers about this code actually had in there that you would need to do an SBIRT. But we actually talked about that a lot and actually met with the powers that be and talked about that if a patient comes with an overdose, it seems kind of silly to do an SBIRT for that patient. So we actually worked with them very closely. And instead, it's going to be has a diagnosis of an opioid use disorder and wishes for recovery. So that will make it a lot easier. The other thing that was in the initial notice is that it appeared to need 2 referrals instead of just 1 referral. So we did work with them again to kind of talk about how that can be a potential roadblock. And what Dr. Costello was saying, right, is what we're trying to do is decrease the roadblocks. We're trying to make this as easy as possible for patients to receive the care that they need and the care that we know by evidence makes a huge difference and leads to long-term recovery and a 50% reduction in all-cause mortality. So really about getting rid of these roadblocks. So we had a really nice talk with them. So really now you just need to make sure that there is a handoff, that the patient has somewhere to go after you do the induction in the ED. Now, again, that could be using the MAR-now number. Or if you have a bridge clinic, or you have a community partner, or you have one of these referral networks, then that is what you would use. Okay, so it's not that you have to use MAR-now, but it is nice that we have it available to us. So you guys have sat through 4 webinars now, and we really kind of want to bring this all together and kind of remind everybody, because you may not have been in all of the webinars, but buprenorphine in the ED is quickly becoming the standard of care. Okay, it is really starting to become something that we need to be able to provide to the patient. And if we're not, are we in fact having malpractice, right? Are we performing malpractice? So we're not offering evidence-based medicine, best practice medicine to our patients that suffer from opioid use disorder. The first step in this was removal of the X waiver. And the responsibility to treat opioid use disorder actually falls on all clinicians. This is not just the ED, but it's the ED. It is the hospitalist. It is the outpatient doctors. It is all of our responsibilities to treat this medication or to treat this use disorder. And not treating opioid use disorder, if somebody says, well, I don't treat opioid use disorder, it's kind of like saying you don't treat hypertension, right? We are physicians. This is part of our scope of practice. We need to get comfortable with this. And this is why these webinars are so important, because we want people to understand the safety of this medication, how to identify how to do this, because it is so important and is becoming the standard of care. We all have unconscious bias, and that is just the way it is. That is how we were raised. We were raised in an era where, use disorders, substance use disorders was really considered more of a choice rather than an illness, okay? Rather than a chronic medical condition, which is what it is. If we really need to recognize it within ourselves so we can address it and then break that cycle. Again, the 80s and 90s were very strong on the war on drugs, and the imagery that comes to your brain when you hear the word war on drugs is very violent. It's very us against them. And really, that's not the best way to do something like this. And a lot of this came from century-old laws, the Narcotic Act, right? These all things that came out from 100 years ago that this was a choice because we didn't understand the mechanism of use disorders at all. Buprenorphine leads to a decrease in all-cause mortality. And I said this earlier, but it's worth repeating, by 50%. So this does save lives. And patients do want your help. We know this from the research that the California Bridge did, is that if you ask, 60% of people want recovery. They don't want to continue using, but we just assume that they don't want recovery, but we don't ask. So we need to ask. Again, this comes from our own unconscious bias that this is a choice. And buprenorphine is safe and effective. The X waiver really was important for us to start prescribing buprenorphine, but it did make everybody think that this was a very special medicine that was hard to use and very scary and all these things, when really it is not. It is very safe. And anybody who's ever prescribed any traditional opioids that is afraid of buprenorphine, this slide is important. Because what you can see from the linear orangey kind of curve there is that traditional opioids, they plateau over respiratory depression. And you can see that buprenorphine plateaus underneath, which means that this is very, very safe. Again, this came from the reason why we needed the X waiver was to basically say that we were giving an opioid product to a patient with an opioid use disorder and that we would not be prosecuted for drug trafficking, again, from a century-old law. Okay, so that's how old that was, which is great that I got rid of it. But now we need to understand this product and understand how safe it is and understand that buprenorphine for the use of pain management has always been available to all clinicians, even without an X waiver. So it was not about the drug. It never was. So again, the X waiver is gone. It is dead. It is gone. Okay, we don't have to worry about this anymore. So please keep that in mind and make sure you spread the word. Now, as for your DEA and anybody on this call, you do require a one-time attestation for your DEA license for 8 hours of substance use disorder training. CME like this do count, and past CMEs also count. And Narcan 100% saves lives. Again, you are unable to achieve recovery if someone is dead. So we have to give them the opportunity. Maybe they're not ready the day you see them. Maybe it takes them a couple times, but they deserve to live. They deserve the chance. And the way we make that happen is making sure that we give naloxone. Now, the solution with all of this definitely lies within us. It does not lie within laws. It doesn't lie within the CDC. It's within us. It's with us, with compassion and understanding, identification, and again, asking the patient when they're ready, are you ready for recovery? This is how we can help in a very non-judgmental way. Again, these patients have been judged a lot. They may be resistant, but showing that compassion can make all of the difference. Now, I want you to remember this, and this comes down to the unconscious bias. If you, and in the ED, we know that non-compliance is nothing new. If you have a non-compliant diabetic that comes through your door that needs insulin therapy and a foot amputation, how would you treat them? This was in my last webinar, and I bring it up again because I think it's that important for you to think about these cases and switching the diagnosis a little bit. Because we would never refuse to give them insulin because it was their choice to not be compliant, or refuse to amputate the foot because they're just going to come back and need the other foot amputated. We wouldn't refuse and say, oh, we're just enabling them to continue to be non-compliant by treating them, right? And we certainly wouldn't just say, well, we will treat your diabetes, but only this time if you promise never to touch sugar, if you promise to go to your follow-up care, right? This is not something that we would do, but this is how we treat patients with opioid use disorder and substance use disorder. So really think about that and remember that. And here is our heroes. Okay, these are our patients with lived experience. We're going to play a little videos for them and kind of give you an update on some of them. Samantha. Unfortunately, your black boxes are back again. Hopefully we can still see the videos okay. But these are, these wonderful people that shared their story with us, the reason why we're here and the reason why we're talking about it, because it's so important to understand why we're doing this. Who are we doing this for? And we will get these videos up because I do think they're very powerful to hear their recovery. Thank you.
The Suboxone has given me time, like a long enough period of time to where I'm not so down in the dirt, like hanging on with my fingernails, and one bad moment and I slip. That's what it used to be. But the Suboxone has helped me get over those times.
Now, Angela is now working part-time and she's taking care of her grandkids. So again, she got a chance. She got a chance to be a grandma. She got a chance to be part of life. Next video, please.
I'm one of the lucky ones because I got everything back that I lost. I know there's so many that haven't. So I think people that I work with would be completely shocked if they knew, my story that's hidden. But
now, Katie got her kids back. She got her husband back. She has a second chance. She is working as a nurse in a skilled nursing facility.
I was spiritually bankrupt at one point. And then with the depression and everything, it was just a really bad time. And I think that's why I just got sick and tired. I said, something has to change. And God finally heard me. And he sent me over there. And instead of telling them that I needed a psych bed, I told them I needed an opioid addiction bed. So I didn't mean to tell that truth, but I did.
I'm so happy you did. I'm so
I
happy
am
you
too.
did.
Life is so different,
So Judith, she is doing great. You can see her happiness and when she talks, which makes us all, she lights up a room. Clearly, I don't know if you guys get that through these videos, but she definitely lights up a room when she goes in there. She's a grandparent. She's still a retired nurse. She's helping her daughter in a recovery house. So she is giving back as well. Next slide, or next video, I should say.
The good thing about it is that I always had that relationship there with that doctor for when I wanted to get clean again. Like I knew that I wouldn't have to sweat it out for weeks at a time, or like a week or whatever. You know what I'm saying? Like I knew that I could transition back easy if I ever wanted to quit again.
So I think Steve here is really kind of highlighting the fact that this is a chronic medical condition and there's relapses. Now, Steve currently is working in the streets department. He recently adopted his nephew from a difficult social situation. So not only did his cycle break, but he's breaking somebody else's cycle, which is pretty kind of amazing. And our last hero here.
We were able to buy a house that we never had before. So yeah, life is great. There's bad days for sure, but I don't have to use over them anymore. I know how to deal with it.
And Crystal is a peer recovery sponsor. She's working at one of our hospitals and again, giving back and doing amazing. So this is just, 5 patients, right? This is just 5 patients here that you can see how much their life changed because somebody showed them the compassion. Somebody said, okay, we're here to help. How can we help you? Are you interested in recovery? So this is what we're here for. We're here for patients like this. This is really important for us to show you guys so you can see the faces behind opioid use disorder and then see what recovery looks like. And you can do this. We all can do this. And that is the best part of what we do here. And we're going to take some questions. Okay. And please let me know when you, I put up some other stuff here. And Samantha, can you help me out with any questions that we may have here? Or comments?
Yes, definitely. One question that we had from our registration where in Chicago or Illinois right now, how many helpline or MAR folks have been helped? Do we know that data?
Yes, so I believe Nikki showed that, Dr. Costello showed that a little bit earlier, but it was around 400 patients have been helped and all of them have been able to be linked to care. 99% of them were linked to care. And the best part is that even on follow-up at 4 weeks, in 30 days, they're still being retained within treatment, which is kind of amazing if you think about it, right? Is that they continue to come, again, because this idea that people want to use is actually kind of false. Once you've been using for a long period of time, you're using just so you can not be sick, so that you can function at all. So there is a misunderstanding of use disorders. And I will, Steve, if you want to unmute and show your face to us, if you have anything to add to that. There you go.
Sure. Yeah, I think, years as an ER doc, I really thought these people didn't get better. I mean, they're discharged, they come back. They're discharged, they come back. But I could not have been more wrong. The people, they get better. All you have to do is treat them. And it's just remarkable. And, even people where you think, oh, the chances of getting better are so tough, the social situation and the lack of funds and lack of transportation. You know what? You just have to, you be patient and you hang in there with them and they get better. They get better. I wish everybody got better, but man, a lot of people get better, and it's just not even that hard. It's about support and compassion, and with buprenorphine and methadone, it's with medication, but people get better from substance use disorder every day.
And I think that's the whole thing, right? Like the definition of insanity is doing the same thing over and over again, expecting a different outcome. We've been doing this for years, guys. Now we've been giving people this, here's a sheet of paper, go find help. And it's not working. But you know what does work? Medication assisted treatment. And we have the literature to support that. So that's really important. And again, patients will come back. And, I think that compassion part, we get some compassion fatigue. But remember, if we were all judged on our worst day, on our worst action, how would we be judged? These patients are very vulnerable. They don't want to be there, and they have to be there. They're a captive audience. This is the time that we can exert that compassion and make a change. Another question, Samantha?
Yes, thank you. Another question. As a nurse practitioner, I have a harder time. I've been having a hard time connecting and getting buy-in from pharmacists. What is one way that you've been able to successfully approach pharmacists at your hospitals?
That's very interesting. I have been fortunate in my hospital because our pharmacists are one of our major champions with this. But I really think kind of talking to them and figuring out what the concern is, really kind of sitting down and having that one-on-one conversation, and even using some of the information you found today about number needed to treat. That is a really important one because, pharmacists really understand number needed to treat. So being able to show them that and say, look at what statins, look at mammography, but look at what we see with methadone or buprenorphine that, 1 in 30, 33, 31 saves a life. Is it a cost factor? Are we talking about what we're stocking in the Omnicell? How to use buprenorphine versus using Suboxone, the combination product, which is much more expensive. So I'd really encourage you to kind of meet with that pharmacist and trying to figure out what the roadblock is. Sometimes it's just miscommunication or misunderstanding. What do you think, Steve?
Yeah, I think it all comes down to education. I deal with this within the emergency department with ER docs, and I also deal with it with pharmacies. A lot of my patients have trouble with pharmacies. They will know when the 1 out of 4 pharmacists that doesn't give them a hard time is working, and that's when they'll go pick up their medicine. And I think it is as simple as really, like you said, Diana, trying to do some education around the mechanism of buprenorphine, the survival benefit, the ceiling effect that you went over, where it's not. But these patients are going to the same pharmacist where they picked up their Norco for a decade and didn't get any pushback, and now they're getting buprenorphine and they're getting pushback. So we have to work on stigma in all of these different situations. And as you said, we're moving in the right direction. Illinois has a lot to be proud of. It just takes a long time.
And Samantha, another question?
Let's see, I think that was all the questions from registration. Folks, feel free to drop any additional questions in the chat.
I do see some things in the chat. Sorry, I'm just looking now. And thanks, Laura. I don't know if I'm saying your name correctly, but you're right. These stories are important, and that's why we wanted to share it. That was one of our main drivers when we all got together and to put on these webinars, and IPHI wanted to do that. We said we need people with lived experience, because us talking about it is fine. We know the technical side of things, but really hearing from the patients themselves on what recovery has meant to them is really, really important.
Yeah, ACEs, that's the key. I think everybody in the emergency department is very, very busy, but if we can highlight these stories, and perhaps at a emergency department meeting, you know, somebody that's sort of leading it, or maybe even get a community provider in to spend 10 minutes talking about 3 patients that used to clog up your ED that are now engaged in treatment and doing well. I think everybody is going to benefit from that. And I think one that you will find, once people get used to buprenorphine, how it works, how it makes people feel better and feel better quickly, that really is an opportunity where they start to question their stigma. Like, oh wow, so this, you know, it's just dopamine, and they're actually very nice, and it just, you will notice that the stigma within the department starts to get chipped away when people are getting the care that they deserve.
And one comment I saw in here was the Ending Overdose Now in Illinois, the rally that is occurring on August 28th, 3 to 7. That is in the chat. So please, again, I agree, great opportunity to connect with stories and harm reduction resources. So the more, you know, it's so great to have you guys all in this webinar. And now we just need you guys to spread the word. We're available for TA if you guys at the hospitals, if the person that made the comment about the pharmacist wants us to come and talk to them, we're happy to. But really, we are very honored to be a part of the IPHI family, to be able to give on this webinar series. We hope that you guys found this useful and educational. You know, sometimes it's just like you kind of have to rip the Band-Aid off and start doing it, and then realizing it's okay. Like many new things, we all kind of get a little bit nervous about it, but there's a lot of support. We are very lucky in Illinois. You do have the MAR now, you do have the doc to talk to somebody there. And, you know, we're all here to help and make, you know, we all went into medicine to really help people. And as corny as it sounds, save lives, right? So we all went into medicine for that. This is really an amazing opportunity to actually do that. So we really appreciate everybody coming and listening to us talk. Steve, anything else that you would like to say?
I don't think so. Just that we are here for you, and plenty of resources available, and we can direct you there, and we can help you. And we talked about California Bridge and what great work they're doing. They have a goal of getting all of their emergency departments to do this in 2025, and they have more than 500 emergency departments. They're already at 200, and I think in Illinois we don't even have 200 total. So I think 2025 is reasonable for us as well. Gives us a couple of years to get this going, and with all of your help, I think we can do it.
And just remember, make the easy choice the right choice. Get those algorithms, take them for California Bridge, work with Epic, work with Cerner, make order sets, just make it easy, and you'll see results. We just know it. So thank you again for being part of this. Thank you for listening to us. We really appreciate it.
Awesome. Thank you all so much. And again, if you would like to obtain CME credits for this webinar, there is a website that we will drop in the chat right now, and you can use this website link to log in as a new or register as a new user, use the enrollment key webinar 4, complete the activity form, and get your CME credits. If you have any questions, if you'd like to sign up for one-on-one TA or ED presentation, feel free to email me at samantha.lasky@ iphionline.org. And thank you all so much.